Good morning, everyone, and welcome to this meeting of the Audit and Performance Committee of the Perth and Kinross Integration Joint Board. Could I just start with an apology for the lateness in starting this morning. As you probably know, we had a special meeting of the Integration Joint Board itself at 9 o'clock, and that has just concluded. So apologies to anyone watching and also to those officers who have been waiting for us to start. To begin, I'll ask the committee services if they could update us on whether there are any apologies for this meeting or any substitutions.
Thanks, Chair. We've had apologies this morning from Ronnie Erskine, but he'll be substituted by Donald McPherson, who is his proxy at NHS Tayside.
Okay, thank you, and welcome to Donald. Right, can I now ask if there are any declarations of interest from members in accordance with the Perth and Kinross Integration Joint Board Code of Conduct? I'll take that to mean that there are no declarations of interest. Okay, if we move on then to the minute of the previous meeting, which is item 3.1. And that meeting was held on the 13th of December. Can I ask if members are content that this is a true and accurate record of that meeting?
Agreed.
Agreed. Okay, thank you. And now we will look at the action points update, which is item 3.2. And I'll ask the Chief Financial Officer if there are any points that she wishes to raise in relation to the action points update.
Thank you, Chair, and morning, members. There are two actions on the action point update. The first relates to the agreement to hold an IGB risk workshop. The slot previously arranged for that was taken up by the very successful primary care risk session, and we're now looking to reschedule the risk tolerance workshop, but we would seek approval from members today to give ourselves up until September to get that in place, given the capacity issues within the team, which should now be resolvable with the capacity agreed, additional capacity agreed by the IGB at its last substantive meeting. So we're seeking just to extend that timescale to ensure that we can support and get the best out of the workshop. The second action point relates to the receipt of assurance from Dundee IGB, which has now been formally received in writing, and that action is now complete.
Okay, thank you for that. Can I ask members if there are any questions on the action point update? Pat Kilpatrick.
Yeah, Chair, I think this is the issue of GP practice sustainability and how we assess that risk and how we manage it is so important. We've recently heard about Rye Hill practice in Dundee going, and there's now Freecombe practice in Angus, and you just wonder which one is going to go next. And the national shortage of GPs continues. So it would be my suggestion, but you don't have to accept it obviously, that you don't defer to September, that you try and run that workshop sooner rather than later, because I suspect this might, that it might take more than one workshop really to come through this. And I think, we need a kind of to start to feed in some of the work that Hamish has done around talking to GPs and, assessing where they all are and what looks viable in the long term and what doesn't. And I think, whether we should be actively promoting the kind of more networked model for GP practices rather than the more standalone model, which is traditional in Scotland. If you look at how they're dealing with it in other parts of the UK, what they try to do is encourage them to work 3 or 4 practices so that they can mitigate the risk a bit by sharing more resources and working collectively together. And if one has an expertise in, say, mental health, they start to take some patients from another practice. There are ways that we could support this rather than just wait for it to start to fall apart. So my personal view would be to urge Jane and others to not to wait, but to take this on and see how much work we could get done. Anything that we can do, I think, will help to mitigate practices shutting their doors and putting padlocks on them. It's just not a situation we want to have. I just feel quite strongly about that, Chair. Thank you.
No, I think it's a very valid point to raise, and as you mentioned, there have been a number of instances over the past few years where this has happened. So, Head of Finance, do you want to comment on that? Perhaps could you give an indication of whether it can be done any more quickly?
So yes, thank you, Chair, and thank you, Pat. Just to clarify that the risk tolerance workshop was around all of our risks and not just in relation to primary care, although I absolutely recognise the key risk that primary care presents, and Hamish very carefully and helpfully articulated that at the last session. What will be helpful to members is the fact that internal audit are undertaking a review of that very risk, and that will come forward to the committee at the end of June, and will set out some of the steps that internal audit believe the system, the Tayside-wide system, needs to take to address some of the risks around primary care. So that will come forward at the end of June. But those were the 2 points I wanted to make. In terms of the risk tolerance workshop, if members are insistent that that takes place sooner rather than later, we will do our very best to make that happen. But I would note the pressures on the team and the capacity issues that still remain.
Okay, thank you for that. Perhaps we can have a further conversation about it offline. Okay, do members have any further questions or indeed comments on the action point update, or can we simply note that? Okay, I'll take that as we can move on. Okay, if we now consider whether there are any matters arising from the minutes of the last meeting. No, okay, that's fine. I'll take it there are no matters arising. Right, moving on then to the next section in the agenda, which is on performance, and item 4.1, which is the locality update from the South locality. And I think we have Tia Dixon and Alison Fairley to present to us. Apologies again for the delay. I know you're probably very, very busy, but we do appreciate you coming along. I think that as ultimately a service delivery organisation, that it is so important to see what you and your teams are doing on the ground. And we really do appreciate the time you take to present to the Audit and Performance Committee. So I'll hand over to, I don't know who's starting, whether it's Alison or Tia, but thank you.
Thank you, Chair, and good morning. My name's Tia Dixon, and I'm the South and Perthshire and Kinross locality manager and manage the health-based services within the locality. I'll let Alison introduce herself.
Sorry, Chair, can I jump in here? I can't find the chat button.
Yeah,
Alison's actually just been on the phone. She's had a personal emergency, so unfortunately she's had to leave. Sorry, she just phoned 2 seconds ago, Tia. Are you able to do the presentation without Alison's support?
I'm happy to do my best, yes. Yeah, I could perhaps do with some assistance in some areas, but I'm sure you'll be able to detect where those are and you can...
You shout me in as required and I'll do my best, Tia. Thanks.
Thank you.
Thank you.
Next slide, please. Thank you. So, as you can see, this is probably a slide that is familiar to most around the screen today. It just gives a bit of a visual about the geography and talks about the population numbers within the localities. It gives you a sense, I think, of the rural nature, and South obviously not being as large as North, but the population numbers between the 3 localities are all very, very similar. Next slide, please. Thank you. So this is some data from Public Health, and it gives a bit more of a demographic breakdown of the locality between the ages and the genders. The percentage of females to males is comparable to that of Perth City, for example. However, the life expectancy in South is longer by over 3 years for men and over 2 for women. and you can see that 24% of the population are over 65 years. You can also get a sense, I think, of the continued rise in the population over the last 5 years, and the biggest rise is predominantly in the over 65 age group, which I think goes a long way to explain some of the increased demand that we're seeing on our services, such as care at home. Next slide, please. Thank you. So just to give a little bit more of a description of the locality, you can see that 21% of the population in South have at least one long-term condition, and this is quite similar to the figures over Perth and Kinross as a whole. At 16% of the population, South has got the lowest figure for prescribed medication for anxiety, depression or psychosis. And the map that you can see describes the levels of deprivation across the area. And while most of the population fall into the ratings of 4 and 5, which would suggest more affluent area, particularly in 8 of the domains, which are around education, employment, housing, etc. What we can't see fully from the map is that there is a sizable group which fall into the most deprived grouping of 1, and that's for access to services. And I think this perhaps translates into what we see on the ground sometimes are a frail older population who continue to live quite well and with few services for a period of time, but then they become very frail and quite quickly require rapid access to multiple services. Next slide, please. Thank you. I'll just give you a bit more of an overview of the structure and the services within the locality. Next slide, please. Thank you. So again, you may have seen this slide before, and it gives a description of the current aligned structure and how the localities are managed within the wider structure and the hosted services, which also feed into the work within the localities. Next slide, please. So within South, we are delivering services from quite a number of sites and locations. There are 8 GP practices, and many of our community nursing teams are based within them, and they are reaching into the whole South locality, responding to referrals. We also have a newly refurbished hub in Bridge of Erne, which has given us a small base for staff and 2 clinic rooms. Initially, this was mainly for the delivery of care and treatment services, but it's also now seeing the provision of some social prescribing in the area as well. And then from our hospital sites at Murray Royal and our community hospitals within South, St Margaret's Hospital and Crieff Community Hospital, we have multiple teams delivering a wide range of services supported by critical admin services. We have allied health professionals providing rehabilitation to inpatients, community and via clinics. And possibly less well known is the King's Centre, which is beside Crieff Community Hospital, and it houses the adult and older people's community mental health teams for the Strathearn area. Thank you. Next slide. So we have some additional sites within Pooler House, and these we have some social work teams here who are based there, and they do provide services to the whole of P&K, but including South. We have the access team, and it's the initial point of contact for referrals that come into a duty team, and then they're picked up and dealt with and eventually perhaps passed on to some of the locality teams if required. The access team is the initial point of contact for the vulnerable persons reports submitted by the police, and these reports are screened within 24 hours, and the management team will determine whether an interagency referral discussion is required or next steps. We have mental health officers also in the team and staff based at James Square in Crieff. Those that are familiar with the locality will know we have a high number of care homes, and we also have 4 areas of accommodation with support and 2 sheltered housing complexes. We have social workers based at all these sites, and again reaching into the community, providing support and assessment. Next slide, please. Within the locality, we have a governance structure which is similar to the other localities. We come together as a group of managers and team leads for monthly clinical governance meetings. At the meetings, we would look at incidents and risks and consider and share any learning that we have. We also look at complaints and feedback, and again with the intention of taking forward any improvements and also sharing learning. These locality meetings then take risks and exceptions and highlight them through the social work and social care forum and onto the wider Perth and Kinross governance meeting on a bi-monthly basis. Thank you. Next slide.
Was that 2 slides that we went forward? Or?
Thank you.
Oh, right,
That's
okay.
great. 2 slides. Brilliant. Thank you very much. So over the last 2 years, the care and treatment service has been going from strength to strength, and we're now delivering from 7 sites and providing wound care, anticoagulation, phlebotomy, and also ear care. We are continuing with a programme of refurbishment and recruitment and also staff training, and that's going to enable the service to develop further and provide chronic disease monitoring, which we have started a phased rollout for. We've also had some key successes for the social prescribers over the past 2 years, and the referral numbers for the Kinross area have now been consistent and on a par with other areas within Scotland. The social prescribers have seen some really positive outcomes in the majority of cases, and a lot of their key work is about reducing social isolation and improving the quality of life for the residents within the locality. There's also a key role reducing health inequalities and looking at mental health and well-being. Within the Kinross part of the patch, the social prescribers are well embedded into the GP practices, particularly at Lochleven. And again, within that practice, we also have an advice hub that's been set up and supported by some of our teams, but also has some other agencies coming in again to provide advice and support to the local community. Next slide, please. Thank you. Another significant development for the locality has been the locality integrated community support. We call it LINKS. And LINKS provides high quality care for people in the area who may be deteriorating clinically at home and require an urgent assessment by a multidisciplinary team. The LINKS team approach is a way of working across health and social care where we intend to wrap around the individual and provide support for anyone over the age of 18 who meet the criteria and are safe enough and wish to remain at home. This model of care is intended to provide a rapid response service to people who are medically safe but have an escalating health or social care need. One of the key aims is to improve patient experience of accessing services and outcomes while reducing the need for emergency or unnecessary admission to hospital or long-term care. Referrals to this service are predominantly from GPs, but they also come from other members of the health and social care team. And what happens is they're discussed every day via Microsoft Teams team huddle. The level of risk is established and the most appropriate team members identified and a plan agreed. Referrals usually remain on links for several days until the situation has stabilised, risk is managed, and the person reports feeling better supported. This links response then dovetails into our integrated care team, which is a weekly meeting where more complex cases can be discussed. And this often involves inpatient discharges, vulnerable adults, or frail individuals in the community. This weekly meeting allows, again, for a multidisciplinary team discussion, which ensures robust communication, exchanges of ideas, and appropriate response, and minimises duplication. I'm sure a lot of people will know that the team in South are really committed and passionate to about what they do, and they absolutely want to provide the best service possible. But we've sometimes struggled to get feedback, consistent feedback from our service users. Some of our teams have recently been testing a platform called Care Opinion, and Care Opinion is a non-profit feedback platform for health and social care. It's largely based around a website, although there are other ways that you can leave feedback. And during the test, all the teams have had quite a significant amount of feedback. And this is dialogue that we really appreciate, and it's vital for us if we want to understand how our services are meeting people's needs. Next slide, please. So through COVID-19, there's been a lot of change about how we've all worked, and a significant change to the availability of support within the communities. Many of our core clubs and groups could no longer meet as restrictions came into force, and the communities within South had to change what they were doing and rally round the most vulnerable, finding alternative ways of meeting their needs and challenges. The food banks in Crieff and Kinross began delivering food, and the Kinross Day Centre delivered meals to older people who would have ordinarily attended the centre. Many volunteers came forward and began using an app to coordinate referrals for shopping, prescription collections, check-in phone calls, and lots of other general assistance that people needed. As we begin to recover, our community workers are providing a critical role, supporting groups with funding sources and practical help to get started. They identify gaps in community provision and support bringing people together to bridge the gaps. We've begun to see the green shoots of a women's group within Kinross, and this will be one of the important additions to the hub calendar for the area. Next slide, please. Thank you. So again, we have an integrated approach to dealing with complex care, which involves meeting to review all the cases across the locality. We look at the cases, discuss progress, and ensure that all avenues of care provision have been considered and explored. I'd particularly like to highlight a new team that, although it's hosted in South, it provides a service to the whole of Perth and Kinross, and this is the Community Respiratory Team, which formed a year ago following an investment. We've got 3 very dedicated staff, Jackie, Claire and Marie, and they work very closely with primary care and secondary care, and they deliver specialist respiratory care and support to housebound individuals with long-term respiratory conditions such as COPD and asthma. People with COPD or asthma living in the most deprived areas are significantly more likely to be admitted to hospital. So the team provide management, education and self-management advice, enabling people to manage their own condition and reduce the need for admission to hospital. They're also currently working with Scottish Ambulance Service colleagues to specifically follow up anybody calling for an ambulance who has a respiratory condition to ensure that they have the right information and support that they need to manage their condition going forward. Next slide, please. So when we come to think about keeping people safe within the locality, we think about adult support and protection, and it's a significant statutory duty across all the localities. Investment has also supported the provision of an NHS Adult Support and Protection Advisor, and they now form part of the multi-agency team. We have locality representation also at the multi-agency Risk Assessment Conference, or MARIC group as it's known. And this is coordinated by Police Scotland, and it's a multi-agency response to domestic abuse referrals to ensure all information is shared appropriately and enable a response for individuals and their wider families that can be affected. Thank you. Next slide, please. Great. I've got some additional performance data that Chris has supported with. So these are some of the national indicators, and these relate to emergency admissions and bed days. When you look at NI12, you can see a 6.6% increase in emergency admissions. This is quite difficult to fully understand, I think, because of COVID and the changes that we've experienced in terms of needs and how we've delivered services. But I think we have to all be mindful of the backdrop of the increased ageing population that we've discussed. NI13 shows a 3% increase in emergency bed days. Again, there's been a lot of COVID-related activity that would be different to what we were doing pre-COVID. And we've described some of the preventative work that we've got underway, and this is certainly a figure that we would hope to see improving. Next slide, please. Thank you. So again, some more performance data from 2021. NI14 shows a reduction in readmissions to hospital within 28 days, and it's slightly lower figure for South and across P&K. This looks to be largely positive. NI15 is about people spending the last 6 months of life at home or in a community setting if that's their choosing, and we can see there's a small improvement there, and again something that we would hope to see continue to improve. Often these are the types of referrals that we get coming through the links, so that's work that we still have ongoing. NI16 relates to our work around falls, which again we see a lot of falls referrals coming through the links team and through shared work with Scottish Ambulance. The figure remains higher than for Scotland as a whole, but slightly lower than last year. And the last paragraph there, NI19, relates to our discharges from hospital. The figure is lower than Scotland, but it does show an increase. But again, 46.3% below our pre-COVID performance. Thank you. Can I move on to the next slide, which is about risk? And the next slide, thank you. So the main risk at the moment, which people can see, relates to care at home provision. And you can see there some of the mitigations that have already been put in place locally and operationally. I think there's I know there's a lot of work going on at the moment regarding the care at home contract and the new care at home model. And I'm not sure if that's the point where Kenny might like to come in and add a bit more detail.
Thanks, Tia. Yeah, as Tia said, there are a number of actions that are being taken there on the right-hand side. One of our key developments that we are implementing is the new care at home wellbeing teams, and they are teams of self-directed carers, which will work in the rural areas and provide care in those far-flung rural parts, which historically we have always had real trouble in actually supporting people in those rural areas. And you know that includes the area from the back of Kinross right through to the Path of Condy, and also up around beyond Comrie as well. Traditionally have been quite hard to support people there. So we're looking at implementing a wellbeing team. We've also increased the hourly rate for the independent sector carers as well, and that's already showing improved signs in terms of recruitment, greater numbers of people applying for jobs, and hopefully that will feed through into greater retention as well, which is just as important. We're also increasing our capacity in our HART, our internal enablement service. And that's across Perth and Kinross, but that will also support the south locality as well. So a number of actions there in terms of significant investment and new ways of working. Also in there we developed enhanced carer posts in the independent sector as well, and they provide improved career pathways for people, which again will hopefully increase recruitment and retention as well. We are working very hard across a number of areas to try and get the message out there in terms of social care being a positive and rewarding career with real prospects. And to help with that, we have recently recruited a digital information officer to help us make sure we're utilising social media and electronic advertisements to the highest extent. We link in with Social Care Academy, we link in with local employers, we link in with local colleges and universities as well, to try and increase the amount of people applying for posts. And just the final one there as well, we have implemented interim beds in care homes as well, and that's for people who are delayed in hospital whose care package isn't ready due to a lack of availability. So instead of being stuck on a hospital ward, which is totally inappropriate setting for them, they can move to a care home, which is a more appropriate setting, until their care package is ready. But like I say, we are confident that the number of people requiring interim beds in care homes will reduce as we increase the capacity in our wider care at home model and implement these new ways of working.
Thanks, Kenny. Can I have the last slide, please? Thank you. So just to sum up, we have learned a lot through COVID, for good or ill, and we know more now about how we can deliver services in a different way. We've become more proficient at using technology, which is useful for reaching remote areas and is certainly a route that some people want to access services from. It's no secret that staff have struggled and worked very, very hard throughout the pandemic, and we have a lot to do to thank them for that, but to build back up their resilience and ensure that they're well. We have some recruitment challenges that we are facing with regard to registered staff, but that is not unusual and is a national difficulty. So the focus going forward is really going to be about trying to remobilise our services and recover from what we've gone through. We have a lot of training and development that we need to provide for staff, and we need to re-engage with the communities and use what we've learned to explore and develop some new initiatives and new services. We also, as I said, need to create better routes for feedback so that we can more actively use that feedback as we develop and change and improve. That's my last slide and the end of the presentation. I'm happy to take any questions.
Okay, thank you very much for that, Tia. That was very interesting, and thank you for going through that update. What I'll do is I'll ask if there are any questions that members have on the presentation, if you're happy to take any.
Thank you.
Okay. Yeah. If members could indicate if they have any questions in the chat. Okay, we'll start with Maureen Summers. Maureen. Can't hear you or see you. There we go. That's you.
Myself, sorry. Yeah, when Kenny was speaking there about beds, you know, extra beds and that for people to be discharged from hospital and go into a care home until their home package was ready. What about the people with challenging behaviour who will always need to be kept in, you know, a hospital safe environment? Does that include beds for them too? Because that was spoken about, and I was told at one time there would be 15 beds for these people, because there are people stuck in POA at Murray Royal who have complex needs, and some of them, their relatives have tried to get them placed in a care home, but even when they did come into a care home, they only lasted a week or so, and they were put back to the hospital because they couldn't deal with them. So what's going to happen to these people?
Yeah, no, sorry, those interim beds I was referring to, Maureen, they're for people who've been assessed as able to return home from hospital with a care at home package. So it's not people, sorry?
It's only for those people, not for people with the...
These are just short-term beds, just until people's care packages are ready. No, that's a separate issue which we are looking at. Obviously, we do have care home beds that can support people with dementia, but yeah, there is an issue which we have discussed a few times in terms of people who have dementia with behaviour that the services find challenging, and yeah, there is an issue there, and we are looking at developing specialist beds to support them so they can come out. I see Zoe's got her camera on. I'm not sure if Zoe wants to come in and add a bit more detail to that.
Yeah, no, it was just to say that we're working with one specific care home at the moment who are allocating one of their wings specifically to dementia, Maureen, and I had conversations with them last week about the training and instruction that would need to be put in and around that to ensure that they were able to work with some of these individuals that you say that are much more complex in their presentation. So we'll be working very closely with our health colleagues. I don't know if Amanda will want to comment at all in terms of support that will be available from our community teams in and around some of those complexities.
Okay, so that's ongoing then, is it? Yeah.
Yeah, it's ongoing. The particular care home is in the process of updating the actual building itself, the wing, to make sure that it's appropriate, and the training is in the first stage and then going into the second phase to ensure that the staff are appropriately skilled up, because at the moment I suppose they would be working with people with dementia, but perhaps not quite that level of complexity.
Thank you. Thank you.
Amanda, did you want to supplement that?
Thanks, Chair. Yeah, I was just going to add to that. Thank you. So I suppose from the POA ward perspective, there's a piece of work ongoing at the moment, Maureen, just to examine,
you know, the capacity and flow around that and the issues that you've outlined there. And we're also looking at how our community teams can support the more complex patients, such as the dementia patients, into those transitions into care homes. So that piece of work is ongoing and we're trying to enhance that just now. Thank you.
Thanks, Maureen, for your question. The next question is from Sandy Watts. Sandy.
Thank you, Chair. Thank you for the presentation, Tia. That was really interesting. You mentioned challenges around staffing, and I wondered if there were any staff roles in particular that were difficult to fill, or whether it was just generally across the board. We talked at the IJB meeting about difficulties in the Highland area, and I wondered if there was similar for the South locality.
Sandy, thank you. It's something that's been changing over time, and it probably started with recruitment difficulties to maybe key staff groups, but I can say now that it's pretty much across all the registered staff groups. So whether it be nursing, mental health nursing, consultant psychiatrists or allied health professionals, we do recruit, but we've certainly seen the numbers dropping, and it perhaps takes longer to secure the right candidates for posts. So it's something that we've known for a period of time, and we have been working on locally, but also with our NHS Tayside colleagues.
Okay, thank you very much.
Okay, thank you. Tia, if I could ask a question, if possible. You mentioned about the community care and treatment hub in Bridge of Arn, following on from the closure of the GP practice, and I suppose that links back to an earlier discussion about the sustainability of GP practices, which is something that comes up quite regularly. Do you think that that's you know, clearly it's not providing all of the services that a GP practice would, but is it plugging the gap sufficiently? How's it being received in the local community? Could you just maybe give us a bit more detail on how that's working, please?
Sure, thank you for the question. I think there's probably some answered questions there for us, just in terms of detail. We know that when the practice closed and people were allocated a different practice, initially we had some difficulty in raising awareness about the care and treatment service being available within the area where they live. So we have done a bit of local promotion, and as a consequence to that, the care and treatment has had a better uptake. So I think we are providing some services, perhaps not all, but I think also that we need to think carefully about what is actually required in the local area, because perhaps there's been a bit of a shift. If people are travelling for the GP, perhaps there's a bit of a shift in how they are accessing services too. I'm not sure if that answers your question.
No, I think that's helpful, and I suppose it's something that you know, we'll have to wait and see how it continues to develop. But it was really interesting that you referred to when you talked about deprivation, about rurality as well, because that's something that's often forgotten. And with my council hat on as well, you know, and those of us who represent more rural wards, it is something that we are keen to see factored into the decisions. You know, you highlighted some of the issues, again, being a bit parochial in Kinross, that we've had the problems north of Kinross with finding people for care at home. So it is, I just think it's useful to see it through that lens. So that was helpful that you highlighted that as well in our decision making going forward. So thank you. Any more questions? No? Okay, well, thank you very much, Tia, and especially for having to do both halves of the presentation, and we hope everything is okay with your colleague. Okay, right, well, thank you. We'll move on then to the next item on the agenda, which is item 4.2, and that's the 2021-22 financial position, and I'll ask the Head of Finance to speak to this report. Jane.
Thank you very much, Chair. The 21-22 budget set by the Integration Joint Board in March of last year supported break-even after application of £3.48 million of reserves. The last financial update received by the Audit and Performance Committee in December set out break-even, but after application of only £1.5 million of reserves. So at the last meeting, we were able to demonstrate an improvement in the position, mainly due to underspend in the core position of both health and social care. The report before you today sets out a further improvement, and we're now able to report a forecast underspend of £767,000 without the need for use of any reserves. The most significant contributing factor to this improved position is the Scottish Government's confirmation in January of this year that slippage and savings will now be deemed a COVID cost and will therefore be entitled to be covered by COVID funding. And this has directly led to a £1.8 million improvement in the core forecast position across both health and social care. Over and above this, the health forecast has improved by just over £500,000 since the last report, mainly due to an improvement in the forecast position on prescribing. COVID remobilisation costs are now forecast to be £9.4 million for this year. That's an increase from the position reported to you previously. Of course, this now includes savings slippage. Of this, £4.5 million will be met by the IJB's COVID reserve, and the balance covered in full by Scottish Government allocation of additional funding in full. Financial risks have been identified in the report that may still impact on the financial forecast. The most significant financial risk relates to ongoing discussions in relation to a £3.1 million overspend forecast for inpatient mental health, which currently sits within the NHS Tayside year-end forecast, for which a contribution is being sought from the 3 integration joint boards. The 3 IJB Chief Finance Officers have been working together to develop a pragmatic response to that request and will be seeking to bring forward a proposal to IJB at its meeting in March in that regard. In relation to reserves, I would note that as at the 1st of April, the IJB was reporting £13.9 million of reserves, both earmarked and unearmarked, and we provide an update on that in the report. I would note at 7.2, an error, we have set out that break-even was to be achieved through use of £5.287 million. Of course, that should read £3.483 million to be consistent with the report and the earlier paragraphs in the report. I've set out for you that we now require not to use any of that £3.83 million. Within that £3.483 million that we'd expected to use, of course, is £1.4 million that was transferred by NHS Tayside to support the financial position this year, and alternatively to be used for shifting the balance of care proposals should it not be required to underpin the in-year position. And again, I would advise members that the CFOs across Tayside are working together to develop a proposal to take to NHS Tayside that would seek to combine that with support also provided to Dundee IJB, and therefore a total of £3 million that would be used to support a shift in the balance of care in relation to mental health services across Tayside. And again, we'd hope to bring a proposal back to the IJB in March in that regard. That was the update on the month, on the year-end forecast. I'm very happy to take any questions.
Okay, thank you very much for that, Jane. And as you say, very positive. I know it's something that we had raised a number of times about the slippage in savings, and I think that the chair had made representation. Not saying that it's Perth and Kinross IJB that made the difference there, but it is welcome nonetheless. Any questions on that report? No questions? Okay, well, we are asked to note the position, and there are a number of recommendations there. Are we happy to agree those 4 recommendations? I'll take silence as agreement. Okay, thank you very much. Right, we move on then to item 4.3, which is the performance report, and I'll ask Chris to speak to this. Chris.
Hi there. Good morning, Chair. Good morning, Audit Performance Committee. Thanks very much for the introduction. I'll go through some of the highlights in the report and then pause for questions. Some of this, the data contained in here has been referenced previously in the PowerPoint that you received, but that was obviously in respect to the South locality only, whereas this report covers the whole of P&K. So this is a key strategic performance indicator report for Q3, and insofar as data is available up to that point, and continues our quarterly performance report to the Audit Performance Committee. The report provides the committee with an overview of performance against these key strategic indicators, and the details set out at Appendix 1. Comparing to Scotland overall, in the year to date, we've got 7 of the indicators for which data is available, 5 being green, 1 amber, 1 red. The red indicator relates to readmissions, which we've discussed previously at the committee, and just remind the committee that due to recording variances across Scotland, it's where it's helpful in other indicators to compare to Scotland, that is an indicator that is not so helpful given recording variances, and therefore that's not really a meaningful comparison. So in that respect, if we compare to the previous year's performance, we can see an improvement of 9.34%. The indicator which is amber is NI16 and relates to emergency admissions as a consequence of a fall. Scotland and the peer group, compared to Scotland and the peer group, Perth and Kinross increased by just over 3% and just over 16% respectively. If we compare, however, to 2021, Perth and Kinross has actually reduced the rate of falls, which is a positive move, by 4.52%. It has been reported previously we've undertaken significant research in this regard, and the Head of Health is looking to bring forward improvement actions, and those will be set out within the Older People Strategic Delivery Plan, which is due to be considered by the Integration Joint Board later this month. Improvement actions, moving on to that section. So we continue to develop our patient service user feedback survey. We've referred to this previously, with a successful pilot stage 1 in the latter part of the last calendar year, and we're currently in the pilot stage 2, and assuming that goes well, we will take the learning from that into the following financial year, where we'd hope to be able to provide patient service user feedback across a much broader range of services. Integration Joint Board recently approved the Community Mental Health and Wellbeing Strategy, and more recently the Learning Disability and Autism Strategy, and as I referenced a moment or two ago, we'll consider the Older People Strategic Delivery Plan later this month. The approach that we're taking underpins each of these strategic delivery plans with outcome-focused performance management frameworks. As I say, most recently will have been seen via the LD Autism Strategic Delivery Plan. Committee members will see that there are a number of PIs that we habitually are not able to provide data for throughout the year, and that's ostensibly because the data is only gathered either 6 monthly or annually. But we are taking steps to see what can be done to provide more localised information and or data to try and supplement where that's possible. So just to wrap up, excuse me, comparing performance against last year can be challenging due to the variances that we've discussed previously. However, if we compare performance to Scotland and our peer group, we remain broadly within the target range. Happy to take any questions on that.
Okay, thank you very much for that, Chris. Can I ask if there are any questions on the performance report? Pat Kilpatrick. Pat.
Hi, thank you for your report. As ever, on the readmission rate within 28 days of discharge, so the data, the way that data is collected and analysed, what you're saying is that it's not comparable against other data sources in Scotland, and that's fine. I understand that, but are we taking any steps to collect data which, although we can't compare it to national data, we could start to see whether there's a year-on-year trend here, or whether it's going up or down, or, you know, I know there's lots of reasons for readmission, and it might not even be readmission with the same diagnostic related group. It might be readmission for something completely different, but I just think that's my first point too. I just think we need some data there, even though it's, you know, whether we do an audit or we do, you know, a deep dive every 6 months. And the other point I wanted to make was, as chair of P&R in the health board, and I'm beginning to sound like a broken record here, but we never get any performance data on primary care. We don't get any performance data on mental health. So we can't ever say, you know, whether people being discharged from hospital are followed up within the 7 days. Is the admission rate for inpatient mental health going up? Is community mental health? Many people are presenting at distress brief intervention service instead of being referred into the inpatients, and we never get any real data on learning disabilities. So I know this is data that's collected nationally, so we have to provide it nationally, so we just bang it in a report and it comes here. But I do think if we're going to do performance management meaningfully, we need to start to say, of the services we provide, what is the performance and how do we report that? And we're in the eye of a storm continuously with community mental health and with mental health generally, and we don't have any indication of the performance. Thanks, Chair.
Okay, thanks for those 2 points, Pat. Jane, were you wanting to comment first?
Yes, thank you, and I'm sure Chris will want to come in. I absolutely recognise the point that Pat is making, and it's exactly why, as we've brought forward our strategy for community mental health and our strategic delivery plan for learning disabilities and autism, that we have committed to develop performance frameworks. The Learning Disabilities and Autism SDP that was approved at the last substantive meeting of the IGB contains such a framework, and that will support us to report from early next year on exactly what you've described, Pat, so we're able to understand the difference that we're making to those set of services. Now, you're absolutely right. For community mental health, we are working to develop that framework. It wasn't a core part of the strategy when we sought approval from the IGB, so we're working on that now, and we'll be seeking again to have that brought forward to the next meeting of the committee, so that you could see how you can now measure the success of the strategy. And likewise, the older people strategic delivery plan, again, work going on right now to try to make sure that when that comes forward at the end of March, there is an integral framework that gives you the confidence that moving forward, the huge investment that's going in is actually making the difference and delivering on the objectives and the ambitions of the IGB. So, interestingly, in relation to primary care, one of the things that has come out of the risk workshop that Hamish led is a commitment by Hamish, certainly to the executive management team, to similarly bring forward a strategic delivery plan for primary care, and we would hope as part of that work on what the 3 years look like in terms of next steps to ensure sustainable primary care services, that we aligned a performance framework to that. So rather than come up with that now in isolation, again, we're looking to build it as we look to build the SDP itself. So that, and again, Hamish is seeking to bring that forward in the next 6 months with an integral primary care performance framework also.
Thanks, Jane. Chris, did you want to add anything?
I think Jane's covered the second part of the question really well in respect to the SDPs and developing performance management framework, so I'm grateful to her for that. I think Pat had made an earlier point in respect to readmissions, which I'm happy to comment on, and about the availability of the data. So in the report, we, across the indicator set, we track our performance against the previous year, so 2021, and we also compare ourselves in year to the peer group and Scotland. So in respect to this particular indicator, as I said, the references to the peer group and Scotland are less helpful for the reasons that Ms Kilpatrick described, and she's quite right as well that the reason for readmission can be completely unrelated to the earlier stay. The point I was wanting to make, however, is that the comparison to the previous financial year is that we've improved by 9.34% against that indicator year on year, and when it comes to the annual performance report, we would report against that indicator as we would with each of them against the preceding years as well, so that a trend of the type that Ms Kilpatrick I think is looking for will be visible.
Okay, thanks, Chris. Pat, does that answer your two? Yeah.
Yeah. I mean, yeah, absolutely. Yeah, and thank you for that, Chris. I appreciate it. Thank you.
Okay, thanks, Chris. Thanks, Pat. Any further questions on this report? No. Okay. Right. Well, thank you very much for that, Chris. And we're simply asked to note the partnership performance report for the period ended 31st of December, which is Q3.
Thank you.
Okay. Thank you for that. Right. Moving on then to the next section of the agenda, which is governance and assurance. And the first item is item 5.1, and that is the strategic risk management update. And I'll ask the Head of Finance, Jane Smith, to introduce the report.
Thank you very much, Chair. The Perth and Kinross Health and Social Care Partnership Executive Management Team routinely monitors, reviews and provides a report to the Audit and Performance Committee around the nature and extent of the strategic risks to which the IGB is exposed in pursuit of its strategic objectives. As part of that review, we look at operational risks, and as part of operational risks, we now routinely consider clinical and care governance risks. Our most recent review has led to a change in our risk assessment and an increase in our risk assessment in relation to 3 specific risks that are set out in the report, and those are leadership capacity, corporate support and inpatient mental health services. I should note, however, that the leadership and corporate support increase in risk was specifically in relation to, at the time, the concern at any gap that may arise in terms of leadership of the Health and Social Care Partnership. And with the appointment to the Interim Chief Officer post of Jackie Pepper, I'm delighted that our most recent work to look at those risks locally within the Executive Management Team sees those risks come back down to their previous levels, which hopefully provides assurance to Audit and Performance Committee members. Inpatient mental health, however, remains at red, even based on our most recent risk assessment. And that reflects the significant discussions that are going on at Chief Executive and Chief Officer level across Tayside in relation to the integration scheme, the accountabilities and responsibilities for mental health across Tayside, and the proposed leadership arrangements. And on the back of the uncertainty currently, that risk has increased to a high risk. The report sets out an update on the number of improvement actions that continue to be taken forward to try to mitigate the high risks that the IJB are facing, particularly around primary care, as has been mentioned, finance, workforce, externally commissioned services, a number of risks that continue to rightfully be of concern to the IJB, and the report sets those out. But I'm very happy to take any questions.
Okay, thank you for that, Jane. Are there any questions on this report? Right, first question from Donald McPherson. Donald.
Sorry, having problems getting to my unmute button. Thanks very much, Jane. I mean, I'm conscious I'm not a regular attendee at these meetings, but I do find this a really useful and informative report, and I like the structure of it. So, you know, well done on that. I noticed that you've archived the strategic risk around preparation for, well, future COVID or other pandemic pressures, and this may well have been discussed at a previous meeting, but I was just interested to know how, before you archive that risk, how do you capture all the lessons learned from what we've been through over the last 2 years and make sure that they are there in waiting for any future recurrence?
Okay.
Yeah, thank you, John, for the question, and I'm delighted that you've raised it, because it obviously is part of the update that we've provided, and I failed to mention it. We have, the executive management team have given this careful thought. It was raised at the last meeting about the decision to archive the risk, so we have thought long and hard. We've reviewed the controls that we've got in place, that we've continued to kind of review and consider as the different waves of COVID have hit us, and we are now comfortable that the effective governance, the command structure, and the wider processes and procedures that we have in place are sufficient, are working, are effective, but we will continue to keep that under review. And should there be any requirement to re-escalate this as a risk, we're very thoughtful of that. But as things stand, the executive management team believe that the governance is very effective, and we continue to build on it through lessons learned. We've taken quite a lot, just to reassure you, taken quite a lot of time at our Gold Command and at our regular executive management team meetings to consider, to discuss, and to reassure ourselves that that is the case.
Okay, thank you, Jane. Thanks.
Okay, thanks, Donald. The next question from Councillor Duff. Councillor Duff.
Thanks, Chair. My question is in relation to the kind of general Appendix 1 on page 49. It was more a kind of in the round kind of thing, and we've got 12 risks there, and we've increased 3 of them up to priority 1. So we now have 10 priority 1s and 2 priority 2s, and it was more a case of, you know, I suppose it's that kind of interrelationship between the risks, if you like. If we are in, you know, can we increase them all to priority 1, or should we actually be looking at, you know, what are the key priority 1s and pushing some of the other ones down maybe into priority 2s, or can we tackle them all as priority 1s, I suppose, is what I'm saying. If that makes sense.
Thanks, John. Jane.
Yes, thank you, John. And it's a really good question. you'd note my comment earlier about the postponement of the risk tolerance workshop, and I think that, you know, that is the downside of postponing that event, because that would give us some significant opportunity with IGB members to consider our tolerance, you know, across the number of high risks. I think, unfortunately, we've got a duty to mitigate all of the high risks. It's very difficult to pull out ones which are more important than the other, and they are interrelated. But what I would say is our regular review, and I've mentioned already that, you know, 2 have gone up, but we're now looking to bring them down. That relates to leadership and the corporate support capacity. In relation to the financial risk, again, I'll be coming forward with a budget paper at the end of March, and on the back of that budget paper, I'm very hopeful that we may see the financial risk reduce from what it's been for a long time, from high red to amber, but that will be conditional on the, you know, consideration of the IGB of the budget proposals. So there's movement there also. The workforce plan will come forward to the IGB in June, and that's a key mitigating action also to what is a significant workforce risk. We've got a paper coming forward in our redesign of care at home, which is a mitigation to our external commissioned services risk. So we're continuing to bring forward key mitigating kind of improvement actions that should see this morph and change on a real-time basis, John. But with the involvement of the IGB through the IGB meetings and in bringing forward particular pieces of work, so that IGB can fulfil its role in ensuring that it's doing all it can to mitigate against these risks. So I don't think we can pick out particular high risks, but what I can assure you is it's ever moving, and there's various actions being brought forward to do that.
No, thanks, Jane. That's helpful. As I say, I think it's, you know, I could understand, you know, in time we'll reduce some of these. It'll be good to see and get the risk workshop and try and make the risks more manageable, perhaps. Thanks.
Okay, thank you. The next question is from Maureen Summers. Maureen.
Yes, regarding the high risk that you have there, that's red for inpatient mental health services, I just wondered how that is going to move forward, because the subgroup that was proposed to discuss the way forward on the inpatients mental health beds was it never happened, and apparently Claire Pearce announced at a meeting a few weeks ago that it was postponed, and we don't know when it's going to reopen. But I can't see it progressing beyond red until that meeting is you know, put in place again. It was interesting to hear that you said there's lots of discussion going on with chief executive and chief officers across Tayside. So is it only the EMT that's going to make decisions on the inpatient mental health beds? Because David Strang was quite clear that it needed, you know, input from people with lived experience. So I don't know how you intend to progress it at all from red until something like that is put in place again.
Jane, do you want to comment on that?
Yes, it's important for me to note, Maureen, that this red categorisation in relation to inpatient mental health is not in relation to operational or clinical care governance risk. That's not the responsibility of this IGB. What the risk that's been outlined in relation to inpatient mental health is in relation to the governance arrangements and the lack of clarity about responsibilities for strategic planning. That's what this risk relates, and to the further work that's going on at chief executive level to making sure there's absolute clarity about the responsibility across Tayside for the strategic planning of mental health services and how that ties in with the leadership arrangements that we have, you know, particularly in relation to Perth and Kinross IGB. So it's not in relation to operational risk, it's not in relation to clinical care governance risk, it's in relation to IGB strategic risk around clarity around the governance arrangements in relation to strategic planning. It's important to make that clear, and I'm not in a position, Jackie may want to comment further, but I'm not in a position to give an update on those discussions, but they are ongoing and taking place, you know, on a real-time basis, particularly given the need for the integration scheme to be finalised, you know, within a defined time scale.
Thanks, Jane. Just
That's
before,
okay, but I
sorry,
feel
Lauren.
that they're all interlinked, and that, you know, it's not going to move until all these other, the operational and everything is put in place. Like, you know, nothing's going to change. You know, it's just like, oh, this is our bit, we don't deal with that. You know, and you get that continually at meetings. You know, when I bring this up, and it's just not good enough. Nothing's going to move forward until, you know, it all works together. Like, you know, rather than, oh, we don't deal with that bit. You know, that's operational, you know, so
I think Maureen,
just observing, you know, that it's
what I might ask is, Jackie, you might want to come in and comment, but I know it was discussed at the last IGB where we had asked the Chief Officer at the time, Gordon Patterson, whether he could give us an update on potential future arrangements. You know, one of the suggestions was having a joint committee or something like that with representation from all of the integration joint boards across Tayside. So it'd be useful perhaps at the next IJB to get an update on that. And also as a secondary point to get an update on the short life working group. Because you know, as was articulated at the last IGB, I think we in Perth and Kinross are very keen to see that work progressed. But as Maureen highlighted, it was suggested that it's been paused. But you may or may not want to comment, you know, right here and now, Jackie, but if we could get an update at the next meeting, the IGB, that'd be great.
Yeah, happy to bring an update in due course. Thanks, Councillor.
not hearing you.
Can you not hear me?
You're very quiet. That's better.
Happy to bring an update in due course, and just to confirm, this is morning of day one for me, and I know that I'll have at least 2 or 3 meetings on that very subject this week, and our Thomas Glenn, who was here earlier for the earlier meeting, is actively pursuing that, and I think Mr. Archibald has returned or is returning to work, so we'll pick that up very early on this week. So that those are ongoing, Maureen. Those conversations. Thanks.
Okay, thanks, Jackie. We'll give you at least a day to get your feet under the table. Okay, thank you for that. Pat, did you have a question, or was it on this topic?
Well, it's just on where does the Blair Gowrie Cottage Hospital closure, or you know, what the plan is for that, and where does it feature? Is it in the primary care risk, or is it in workforce risk, or where is it? What's the plan for it? And you know, it's not mentioned anywhere. And I don't know whether there are other smaller units like that with GP beds that might be in a similar situation, Chair. I just think that to me was quite an important issue, and I just don't see where we're picking it up. Thanks.
Okay. Who would like to? I see there's 3 of you who've got your camera on. So who's wanting to take it?
Amanda, I think you're probably best placed to talk to that, if that's okay.
Yeah, thank you. So probably just a point of clarity. I think you mentioned, Pat, if I heard you correctly, Blair Gowrie. So there's no closure in Blair Gowrie. I think maybe what you're alluding to is the temporary.
I didn't mean Blair Gowrie, I meant Pitlochry. Sorry, and my apologies.
Just to be clear, thank you.
I didn't mean Blair Gowrie, no. Thanks.
That's okay, thank you. So I think just to say that, as you know, Pitlochry has become a non-operational unit for the GP unit, and we're currently progressing plans around that to ensure a reopening of that unit. So that's due to registrants being unavailable to support the workforce, and we're actively pursuing plans to address that. We did bring a paper to IJB just 2 weeks ago, which was approved to allow us to progress and get some project support to look at that going forward. So that's an active development. Thank you.
Do you not think it should be in the strategic risk and any other small units like that with GP beds? I mean, if it can happen at Pitlochry, it could happen anywhere, but I don't know if we've got other small units. just think it's quite an important issue, and it doesn't feature in the risk anywhere. I mean, we've lost GP beds, and I understand all the reasons, and I was at the IJB when the paper was presented, and I agree with it, and I think to applaud you for the work that you're doing, but I do think we need to log it or register it. It needs to be mentioned somewhere. You can't just shut down something like that and not say that it looks as if we didn't know it was a risk and it just happened. I don't know whether that's true or not, but I don't think that's the way that it did happen, and I think we just need to have it noted somewhere.
Thanks, Pat. Jane, you wanted to come in?
Yes, thank you. Pat, the paper that Jackie will come on to talk about in terms of the clinical care governance escalation report intends to do exactly what you've outlined, which is consider the high risks that are being highlighted as part of our clinical care governance processes, and consider whether we therefore need to reconsider the level of IJB strategic risk thereon. And what you'll see in that report is we've done exactly that. We've looked since the last report at the two further clinical care governance reports, the NHS Tayside Care Governance Committee, and consider where we need to potentially escalate the IJB strategic risk, and that's the new process that is now in place. So perhaps as part of the clinical care governance escalation report, that will be covered and provide you with assurance that we are regularly looking at clinical care governance risks, of which the workforce issues in our inpatient services are there and will be picked up as part of that process.
Matt, did you want to come back?
Yeah, I mean, I think I was one of the people who fought so hard to tooth and nail to get care governance on the agenda for this committee. So, and I have read the report. I personally just think it needs a mention in the strategic risk. It's a big deal to have to close GP beds somewhere like that, and there might be other places in a similar situation. And then we can always say we picked it up, we registered it. I know it's a care governance risk, I understand that, but I just feel quite strongly about it, Chair. But it's entirely up to you. Thank you, Jane.
I think we did have a long discussion about this at the pre-agenda meeting, without wanting to go sort of too much into the detail, where we did think that it was important to sort of join the dots between what the care governance risk was and what that impact was on the strategic risk. So we had talked about and slight amendment made to the paper about referring to the strategic risk within the care governance paper, but we can certainly have a look at whether we need to also refer back the other way, and that's something I think as you know it's something we've pushed for quite some time. Yourself, myself, others, we've recently got it. I think it's still a case of sort of teething and seeing to try if we can get it right.
Thank you.
Okay, but I see that Jackie wants to come in as well.
Thanks, Councillor. I just wanted to, for a matter of the record, go back over the conversation at the last IJB that I was present at, where Sarah Dickey, as professional advisor from the nursing directorate, was indicating that this was a workforce matter and was not a matter of care and clinical safety issues. So it was really just to make sure that we're clear on that when we're saying this is a care and professional governance matter, but it was about workforce and not about patient safety. So I think we just need to be clear about that. Thanks.
Okay, thank you. Any further questions on that or on any of the items in the report? No? Okay, well, thank you for that, and we are asked to note the position in the report on the risk register and the current scores. Happy to do that. Okay, can I just check? We've still got a number of substantive items to go in the agenda. Are people happy to continue, or do they want a short recess? Perhaps members could indicate one way or the other.
I think you should keep going, Chair.
I'm happy to continue as well, Chair.
Okay, right. Well, if we move on then to item 5.2, which is the partnership improvement plan, and I'm going to ask Fiona Lowe to give us the update on this. Thank you.
Thanks, Chair. Progress is continuing against the actions on our partnership improvement plan. Over the last quarter, another 4 actions have been completed, which means we're up to 54% of the plan has now been completed. So over the last quarter, the 4 actions include processes for engaging with local communities to co-design services, the process for evaluating the impact of our strategies, which is linked back to our performance frameworks, ensuring that both qualitative and quantitative information is taken into account, and the process for reviewing reports and issuing directions to partner bodies. On top of that, the Chief Officer took the decision not to take forward the restructure of the partnership, and instead we now have approval to increase capacity across each head of service area, and that was approved at the February IJB. So these are the actions that are completed. We have 2 further actions which have moved from amber to green. This is communications with the public. We have a digital marketing officer in post, and they will be linking in with partner bodies. And corporate support, the rapid review has been complete across further investment across performance, and planning has been put in place. Further areas for review include capital planning, communications, and clinical care and professional governance. The one thing to note in the report is that we are hoping to, from next committee, merge the Partnership Improvement Plan report along with the audit recommendations. We have some duplication across actions, although the Partnership Improvement Plan is more strategic in its nature, and audit recommendations tend to be operational. So I'm working with Jackie Clark and how we can provide a correct format for that to bring that to the next committee. So that's a very whistle-stop tour of progress. As always, I'm happy to take any questions, Chair.
Thank you for that, Fiona. Are there any questions from members? No? Okay. That was getting off easy there a bit, Fiona. Okay, right. Well, thank you very much for that update, which is positive, and we'll look forward to the subsequent updates. Okay, thank you for that then. Moving on to item 5.3, which is the audit recommendations update, and the Head of Finance will give us an introduction to this report.
Thank you, Chair. Just to confirm that there's been no audits complete since the last report to committee, and therefore no additional recommendations have been added to this report. I'm pleased to say that we have no outstanding audit recommendations that are overdue. We have 3 that are not yet due, and I'm pleased to confirm that they are on target to be completed within deadline. One relates to our review of a reserve strategy, which will come forward to the March IJB. One relates to the review of financial risk sharing arrangements, which is being taken forward by the partners and is scheduled to be complete within the next 3 to 4 months. And one that relates to management capacity, which, as Fiona indicated in her update, was an investment agreed at the last meeting, substantive meeting of the IJB, which we're now taking steps working with HR to get that capacity in place. So all 3 actions that are not yet due on target to be completed within the dates committed to. Happy to take any questions.
Thanks for that, Jane. A good update. Everything looks like going in the right direction. Any questions on that? No. Okay. Well, if we can just note the progress on the implementation of those agreed audit recommendations. Thank you. Moving on then to the next item, which is 5.4, which is the appointment of the internal auditors, and I'll again ask the Head of Finance to update on this report.
Thank you, Chair. We bring forward today a proposal to appoint our internal auditors for a 3-year period. We consider that this will provide increased planning ability for the internal audit function and a greater level of continuity. Undoubtedly, the internal audit function has been impacted by COVID, both in terms of immediate response within the team and what are ongoing staffing challenges that are not just being faced by our internal audit function, but are being faced by organisations across the country. And we believe that a 3-year appointment to internal audit will support the internal audit function and the chief internal auditor to deliver on a more continuity basis. So the proposal is the appointment of Jackie Clark as Chief Internal Auditor and the Internal Audit Service along with the Tayside Service for a period of 3 years.
Okay, thank you, Jane, for that. And just before we move on, I think it's important to note the background to this, where we did look at 1-year appointments in the past when we were looking more holistically about how we can get our internal audit function. And Jane, I think you spoke to colleagues in other parts of the country, and then we were able to have that clarity around those arrangements and what options were available to us. So I think that it was important that we did that, following on from the discussions at previous committee. But I think now we have that information that it's sensible to look to make a 3-year appointment. But I see there's a question from Donald. So Donald, do you want to ask your question?
Thank you, Chair. Just a couple of questions. One which is maybe just me being pedantic, but I was a little bit confused by the recommendation, where the second bullet first of all says appointing for 2022-23, and then it says for a period of 3 years. So I thought it should be just the latter without the former. And my second question, does the 3-year period also relate to the first bullet point, which is the Chief Internal Auditor appointment? Or is the 3-year period only relating to the two parties named in the second bullet? Sorry if that sounds a bit pedantic, but do you see?
Probably a fair point. It's perhaps not as clear as it could be. Jane, I don't know if you wanted to comment.
No, I can't disagree with you, Donald. I think the recommendations could be far clearer. We are looking at a 3-year appointment from 22-23 for both the audit service and the chief internal auditor hand in hand with that. So apologies that isn't as clear as it could have been, and hopefully that helps clarify.
Okay. Thank you. So that was my first question, and I think that's the right answer. So I'm happy with that, and I think the 3-year period is sensible. My other question was, during that 3-year period, how will we evaluate performance?
Jane, do you want to?
Yes,
comment?
I mean this is a discussion that I have had with the chair. We've discussed it at committee, and I've discussed it with the Chief Internal Auditor too. And what we agreed was to review the timescale for delivery of the audit reports. That was kind of one of the significant concerns, I think, of the committee over the last period, that reports weren't coming forward within the timescale. So we had agreed to set some clear timeframes for the audit reports coming forward, and to monitor against that as a basis of monitoring to an extent the performance. So that said, I think there has been a struggle by internal audit to bring forward against the agreed timescales, but that was the core measure of performance that we'd concluded on. Other than that, I think, and I'd be happy to speak privately with members, I think it comes down to the quality of individual reports that come forward, and the Audit Performance Committee members' consideration of each of these reports and whether it is of the standard that you would expect. The difficulty, of course, is if we're not getting reports come forward within the timescales that have been agreed, there's a lack of ability to make judgment of the overall quality of these reviews. So the timescale is the initial kind of concern, and I know Jackie will want to cover that that within her internal audit update when we get to that on the agenda, some of the difficulties that they faced.
Thank you, Jane. I mean, I think notwithstanding we're making a 3-year appointment, I think it would be helpful to include an annual evaluation as just a checkpoint, perhaps at the end of the delivery of the plan.
I think that was the commitment that we had when we agreed. I can't remember whether it was at the last meeting or the previous meeting, those indicators, performance indicators, as Jane has outlined, you know, the suite is quite limited compared to what you might be able to do for some other ones in terms of you know, how timely the reports are and also the quality of them. But we did get a commitment that the Chief Internal Auditor would update us, I think, annually on those, and clearly there'd be the opportunity to scrutinise that. I see Jackie's put her camera on. I don't know whether she wants to come in.
Thank you, convener, and thank you for the question. As part of my annual report, I would include any relevant information, and the annual report will come to the Audit and Performance Committee.
Okay,
thank you.
Thank you, Chair.
Okay, thank you for that. Any further questions on this report? No. Okay, well, if that's the case, then if I can ask us to look at the recommendations, I'll try to be clear as I can with these. So the first recommendation is approving the appointment of Jackie Clark as Chief Internal Auditor for a period of 3 years from 2022-23. And the second recommendation is that we approve Perth and Kinross Council Internal Audit Services and FTF as the IGB's internal auditors for a period of 3 years from 2022-23. Are members content to agree those two recommendations?
Agreed.
Yeah, yes.
Yes, agreed.
Okay, thank you for that. Right, the next item is item 5.5, which is the audit strategy. And we have with us today Carol Batchelor from KPMG. And I'll ask Carol to speak to this report. Carol.
Thank you, Chair. Just to introduce myself, because I am new, my name is Carol Batchelor. I'm an audit manager at KPMG. I've been with the firm for 25 years, but just recently moved to Scotland. In terms of our audit plan, there's just a few points that I'm wanting to highlight. A lot of our audit plan is very similar to that of the previous year, but the ultimate objective is for us to basically audit the annual report to ensure that it is in line with the applicable code and in terms of IFRS. The audit partner, Michael Wilkie, will continue to be the engagement partner, and he's been involved in this audit for a number of years, and so does bring a wealth of experience. I just want to highlight that our materiality that we've included in our plan is set at £2.3 million, and that is based on 1% of gross expenditure. We base that on the prior year annual report. Once we receive the final trial balance to audit for the 2022 financial year, we do check that number to ensure it is still appropriate. Our audit fee is described on page 5. It is an increase on the prior year, and there has been approval from Audit Scotland for that. Just to go back to our materiality that I mentioned was set at 2.3 million. It is a slight increase from that of the previous year. Our performance materiality is set at 1.7 million, and our threshold over which we will report audit differences is at 100,000. Just in terms of our significant risks and focus areas, the auditing standards ISO 240 does require us to focus on there's an inherent risk of a fraud risk over management override of controls. So that is an area that is a significant risk that we look at. The fraud risk over income recognition is something that we have to consider as well, although we don't, there's not a lot of estimation and judgment involved, so we are not considering it there to be a risk of fraud because of those factors. We also look at a focus areas completeness and accuracy of expenditure. That will be a focus area, as well as financial sustainability. As has been already mentioned this morning, there has been a number of updates in terms of financial sustainability of the board, and a large part of that is additional funding that the Scottish Government has confirmed. So we will be spending a lot of time in the audit, focusing on the grants that have been awarded to the board, as well as any terms and conditions of those grants and how those need to be disclosed in the financial statements. So the grant funding would cover COVID-19 type grant funding, as well as any others. Let's see what else. We will also, from a wider scope, focus on financial sustainability and financial management. That will continue to be a focus area, as well as governance and transparency and value for money. The appendices to our plan emphasises what we have to communicate to those charged with governance, which includes our independence and any other reportable items that we come across that need to be reported to the committee. In terms of our timeline, we'll be starting, we'll be doing some planning work with our final audit field work commencing and taking place in July and into August, and with the presentation of the annual report before the end of September. Those were really the main factors, Chair, that I was wanting to highlight from the report and our audit plan. If there's any questions, I'll be happy to take them.
Okay, thank you very much for that, Carol. I see there's a question from Donald McPherson. Donald.
Thank you, Chair. I just had one question, if I may, and it's on page 6 of the KPMG paper, page 73 for those of us on the PDF, and it's talking about material misstatements, and the paper says that if management has corrected material misstatements identified during the course of the audit, we will consider whether those corrections should be communicated to the Audit and Performance Committee. And I'm just wondering, what's the situation where this committee wouldn't want to be made aware of a material misstatement, because it would be clearly, it might suggest that there has been a weakness in control. So I'm not sure why you would take a discretion either to advise or not to advise.
So I think in all of my experience, we usually always communicate our corrected audit differences for the exact reason that, you know, you've explained. It's important to understand where there has been a correction. The only area I can say from a practical audit point of view where sometimes there is a bit of ambiguity is there might be something that management are wanting to discuss with us as they're finalising their year-end trial balance, which it's not an audit misstatement that we've identified through our audit procedures. It's more of a discussion. And in practice, some auditors would note that as an audit misstatement and others wouldn't. That's the only one I can honestly think of. But I really can't think of a reason why we would not report to those charged with governance an audit misstatement.
Yeah, thank you. I mean, I think I would encourage you to notify any material misstatement unless there's a clear reason for not doing so. I don't know whether other committees or other members of the committee are of the same view.
I think that's a fair point, Donald, and hopefully Carol can take that away. Okay.
Thank you. I will take that away. Thanks.
Thank you. Are there any further questions on this report and the strategy? No? Okay. Well, thank you very much, Carol, for your time. and we look forward to receiving future updates from KPMG. Thank you. Right, now moving on to the next item. Apologies, just because the wonders of technology and working off different documents and supplementary agendas, I seem to have missed out the previous item, which was the internal audit progress report by the Chief Internal Auditor. So apologies for that, Jackie. Would you like to speak to this report?
Thank you, Chair. Yes, this document highlights the progress that has been made against previous internal audit plans. As you'll see from the first appendix, which perhaps gives a little bit more detail as to what the progress is here. The previous audit on corporate support is substantially completed. It didn't quite make the deadlines for this report, and because Jackie Pepper has now taken up post, I felt it appropriate for her to have the opportunity to view the report and make comments prior to that coming forward. But the work is complete and the report is substantially completed too. Internal audit planning is ongoing throughout the year, but for this particular audit period, the planning was complete. And as you've heard from discussions at this committee previously, and at this particular meeting, I'm in ongoing discussions with Jane and also with Fiona on different aspects of the reporting of internal audit work. The annual report is due to come to this committee in June, and that's on track for doing so, along with the two other substantive pieces of work. As you can see below on the appendix, the assignments for leadership capacity, the planning for that has commenced. But again, with Jackie taking up her, the interim post, I want to take that forward directly with her rather than sort of concluding and scoping a piece of work prior to her arrival. The primary care improvement plan, again, the work is substantially complete, and my colleagues in NHS Tayside are drafting a report, and this is a Tayside-wide approach to the review of primary care improvement plans. And I know that my colleagues in NHS have been discussing with Jane only last week about progressing that to a final report. So that is close, but not quite ready for committee as yet. I'm happy to discuss anything on those particular appendices, on that particular appendix, but you will note that there is an additional appendix today, which is as part of our outcome sharing protocols that we have between the IJB and partner bodies. The NHS has declared 2 reports to me which would be of relevance for this committee to be aware of. They are both, as I say, they're both NHS Tayside reports, and I'm not privy to the detail of these reports, but if you've got any particular questions or anything that you'd like to take back, I will find out from my colleagues in NHS and feedback to the committee.
Okay, thank you for that, Jackie, and it's particularly welcome to see the inclusion of the NHS updates as well, because I know that's something we've been keen to see for some time, that information sharing between the partner organisations and ourselves, so that's good to see. Can I ask if there are any questions on the report or its appendices? No, okay. Well, thank you for that, Jackie. And you know, we are keen to see the corporate support report as soon as we can. So we'll look forward to that at the next meeting. Okay, thank you for that. Right, moving on then, and I'll just make sure that both of my agendas match up this time. The next item is 5.7, which is the external audit proposed audit fee for 2021 Now that says 2021-22, but I assume is that 22-23, Jane?
No, it is for the audit to be done retrospectively.
Right. Okay. Fine. Jane.
Okay, thank you. An audit fee, external audit fee of 30,660 is proposed. That is out with the 10% limit set by Audit Scotland in its funding and fee strategy, and therefore, as Carol has said, KPMG have required to get approval for that fee from Audit Scotland, which they have received. That has been justified on the basis of the significant work around financial sustainability and wider scope. So having been endorsed by Audit Scotland, the Audit and Performance Committee are now asked to approve the external audit fee for 21-22.
Okay, thanks, Jane. Any questions on the report? No? Okay, well, we're asked to approve the proposed external audit fee for 2021-22, subject to Audit Scotland approval. Are members content to agree that?
Agreed.
Okay.
Yep, agreed.
Great. Thank you for that. The next section of the agenda is section 6, which is clinical care governance, and the first report is 6.1, which is the clinical care governance risk escalation report. And I'll ask Jackie Pepper to speak to this report. Jackie.
Thank you very much, Chair. I'm pleased to introduce this report, which is the Clinical Care Governance Risk Escalation Report. And as mentioned earlier in the agenda, there's been a request to bring forward information and assurance in relation to clinical care governance to the IJB. This report has been prepared by Jane Smith, and I appreciate the work that she's done on this. And there are attachments which cover the reports that have been provided to NHS Tayside's Clinical Care Governance Committee. And you'll see from this report that the arrangements to ensure that a similar reporting mechanism to the Council Scrutiny Committee has still to be finalised. And at this meeting, in this report, you'll see that the risks identified in relation to meetings in December and February relate to community hospital staffing, mental health workforce and psychiatry of old age and patient staffing. And a number of these matters have already been items discussed at this meeting already. And there are details within the report. I'm keen, I think, from this meeting to receive feedback on the content of this report and the associated appendices in order that we can ensure that this committee is receiving the assurance and information that allows it to perform its functions. So thank you, and I and a range of others that are in attendance would be happy to take any questions. Thank you.
Okay, thank you for that introduction. Are there any questions on this report from members? Pat Kilpatrick. Pat.
Just to say, Jackie, you know, I think it's early days with all of the reporting on care governance, so I thought this was good, and it was honest, upfront, straightforward, easy to read, easy to understand, and basically just it's good to see it and well done. Thank you, Chair.
Okay, thank you, Pat. The next question is from Councillor Duff.
Thanks, Chair. My question relates to page 104 of our pack, and at the bottom there, there's a reference 657 to do with the situation at Pitlochry Creef. But it says in here, escalations planned and developed and signed off by A&D, not quite sure what that is, but to support escalation processes for agency staff taking charge of ward areas. Is that a new development, or do agency staff currently take charge of ward areas within these hospitals or elsewhere?
Amanda, were you looking to help with the answer?
Thanks, Chair. So normally, Councillor Duff, agency staff wouldn't take charge of the area, and this has been agreed by the AND is the Associate Nurse Director. Apologies for the shortened abbreviations. We'll pick that up next time. So the Associate Nurse Director has given us, I suppose, authority to allow that to happen because the number of agency staff that were supporting Pitlochry area were known to us. So we're becoming more familiar with the area, and we did put in some training and education support to allow them to take charge of the ward. Unfortunately, even with these extensive developments, we still weren't able to maintain the safe workforce required.
Okay, and I suppose the issue then might be around about what's the word I'm looking for? But consistency, you know, that it is the same individual for a period of time. Okay.
Yes, so we had maybe 3 or 4 agency staff that were happy to take charge. Some were not happy to take charge. So I think with that, with our current workforce, we had to assess the risks, whether that was safe to do so. So it was felt at that time that we didn't have enough consistent agency staff to maintain the safety of the ward area.
Okay, thank you. I have another question, Chair, if you're okay.
Yeah, okay.
Just a bit further down on the next page under 1071 prison healthcare. There's some text below that, but I'm not quite sure what the issue is around about the risk. If I could just get a wee bit more detail, please.
I can come back on that, Councillor Purvis, if that's okay. I don't have the full detail, Councillor Duff, but that relates to the development of a new female facility in Dundee. So in line with a new facility opening within NHS side, it will be the additional health staffing requirements to meet that, and the identification of the resources to support that. Thanks.
Okay, it's just getting the thing set up and resourced. Okay, thank you.
Thank you. Any further questions? No? Okay. Well, just to consider the recommendations for a moment, we're asked to note the assessment of the partner's operational risks and the assurance set out in the report, and also to note the Perth and Kinross Health and Social Care Partnership Assurance Reports, which were considered at the NHS Tayside Clinical Care Governance Committees, and finally to note the minutes of the NHS Tayside Clinical Care Governance Committee meetings as set out in the appendices. Are members content to agree those recommendations?
Agreed.
Great, thank you. Okay, moving on to the next item, which is 6.2, and we're back to Jackie with her other hat on as the Chief Social Work Officer, and we have the Chief Social Work Officer's annual report for 2021-22. Jackie.
Thank you very much, Councillor Purvis. This report was received by Perth and Kinross Council on the 15th of December 2021, and I know it's been difficult to have this report on the full IJB committee cycle, but I'm pleased to bring this here today to this committee. And the report sets out how social care, social work and criminal justice and children's services have been delivered up until the end of March 2021, and in some cases up to the end of July 2021. So it's covering the last financial year and up to the summer. And you'll see within it, it covers the key challenges in responding to COVID-19 and the impact that this has had on demand in particular, and how teams have adapted to new ways of working. And The report emphasises how our teams are continuing to adapt and tells, where possible, the stories of their experiences at team level. And I think that perhaps addresses some of the questions that have come up today as well, in terms of the impact and experience at frontline level. And you know, the ways in which teams have adapted, increased use of technology, introduction of virtual meetings are all changes that have proven to be efficient and successful and likely to be taken forward in our recovery. So the report also highlights significantly higher workloads at what I would call our front door services, and these are likely to continue for some time. However, the assessment in terms of the way in which our social care and social work services have responded to that is that this has remained good despite these major challenges. But a caution in relation to the increase in demand and the resources required to support that. And I know that Kenny and the additional resources coming to frontline social work services will be helpful in that regard. So that's just a way of introduction to this report, and recognise that this is now quite retrospective, and happy to take up any questions along with others today. Thanks.
Okay, thank you for that introduction, Jackie. Do members have any questions on this report? Oh, sorry, Donald, I didn't see that there. So your camera come on. That's the question. Donald, on you go. Your question.
I was waiting very patient. Chair, thank you. A couple of points, if I can, please. I mean, you know, I think it's a really detailed, a really interesting read, and I certainly found it useful from my point of view in getting a sense of all the things that have been going on over the period. I do have a plea, and I have to say it's a plea that I make in lots of other places, to think about the accessibility of the document to people who use our services. And in particular, one thing that I would love to see in this type of report is, you know, right up front, what are our key performance measures? What did we set out to do over the period? What did we achieve, and what were the outcomes? And I know sometimes we're constrained by national formats, but I think having that sort of information up front would be really useful for those people within Perth and Kinross that just want to be able to get a quick sense of what we do. The other, it was a question around both the source of adult protection concerns, and I think the same point for child protection concerns, that when you look at the tables, the vast majority of referrals seem to come from the police. And I know that, again, I know that's a common trend. I think Dundee IGB sees exactly the same thing, but it does worry me. Are we missing a chance to pick up on the people who might be in need of protection at an earlier stage? Because by the time the police are involved, sometimes it's they've reached crisis point, whereas perhaps we should have picked up the issue sooner.
Okay, thanks, Donald. Jackie, those two questions.
Thanks very much, and thanks for your comments on the report. The report itself has to follow a national format, and I think you alluded to that yourself. There are certain headings that we must provide a report on, and that's because the Scottish Government uses that material to develop a national report from that. But I am happy to hear your comments on accessibility, and the performance being up front. There is a covering report that would go to council on this, because the report is used to provide assurance to council that its statutory functions are being met. And that's something that I'll take forward and consider how this report might be improved in the year ahead. So thank you for that. In relation to adult support and protection concerns specifically, and the vast majority of concerns coming through the police, I think you know, I take your point about how are other services attending to and picking up on concerns about vulnerable adults. But I think there's something in here in terms of the volume and activity that I think is reassuring, in the sense that vulnerable adults have remained visible throughout the period of the pandemic. So I take assurance from the numbers having increased and not fallen away entirely. And but I think it's something that we can, I know we've got a date in the diary, 13th of April, to look at a development session in relation to adult protection. So I think the proportions and the analysis that's underneath that, I think we've got a real good opportunity across the IGB to have a look at that in more detail, Donald, and hear directly from Bill Atkinson and Ian Wilkie in relation to the work of the Adult Protection Committee itself across all services. Thank you.
Okay, thank you for that, Jackie.
Okay, thank you, Jackie. Thank you, Donald. Any further questions from members on this report? No? Okay. Well, thank you very much, Jackie, for your report. Always very interesting to read and to see all the work that is going on across Perth and Kinross. Okay, I think that takes us to the end of the substantive business. We have a number of items for information. 7.1, which is the Audit Performance Committee work plan for 2021-22. The same work plan for 2022-23. And then at 7.3 we have the record of attendance for 2021-22, which I'll take it that members are content to note. Finally, we have the opportunity for a discussion with in private with our auditors. Would any members like to take up that opportunity? No, I'll take silence to mean no. Unless I'm seeing cameras coming on. No, okay, fine. And then just right at the end, we've got the date of the next meeting, which is the 7th of June for the next Audit and Performance Committee meeting. So thank you everyone for attending this morning. Apologies again for the late start, but thank you for your contributions.